Because there are two of you, please do feel free to answer the questions depending on who you feel you wish to answer the question.
Thank you.
Could I ask you first of all, please, to give, if we start with the lady on the left in pink, your name and your professional address and your current post held, please.
My name is Nora Flanagan. I'm the operational manager for the Royal College of Nursing for London, and my address is 20 Cavendish Square, London.
Madam?
My name is Sharon Bissessar. I'm a senior regional officer for North West London for the Royal College of Nursing, and my professional address is 20 Cavendish Square.
In front of you, you should have a bundle labelled Volume 1.
Yeah.
If you could please look at pages 3 to 6 and confirm that those are your submissions. I wonder if you would be able to please put your microphones on. There's a red button, I think, on each. If you press that, it should make them work. Can you confirm, please, that that submission is true and accurate to the best of your knowledge and understanding? I think one confirmation will do.
Yes.
Yes, it is.
And that you wish it to stand as your evidence for the Commission?
Yes, we do.
I just wanted to ask you first, very briefly, about your membership and the responses that they gave. Were the responses that you had received from nurses who were practising throughout the North West London region, or from any particular area?
The responses we received, both verbally and written, were from nurses working across North West London in the community and in the acute settings, in some of the trusts affected, as well as some of the surrounding trusts.
So were they practitioners based in the full range of healthcare environments?
Yes, I would say so.
Yes.
And with differing levels of experience and expertise?
Yes, our membership covers a broad range of experience, from healthcare assistants who are unqualified to very senior nurses working within North West London.
So would you consider the responses as providing an accurate reflection of the views of nurse professionals in the relevant area?
Yes.
Sorry, I'm being asked again to ask you to press the red button, because I think that's what keeps it switched on. I wanted to ask you first of all about the acute hospital environment. Now, on page 4 of your submission, you set out that details of overstretching of accident and emergency over winter period, and that Northwick Park had been on divert numerous times over that period. I wonder if you can help us. Can you expand for us on what happens to patient when a site is on divert, and how is a divert managed, please?
I'll be happy to answer that. My professional background as a registered nurse is actually in accident and emergency. And
Could you speak up?
And I've worked in 4 accident and emergency departments in North West London. Just to explain what a divert is a request from a receiving trust for ambulances to avoid approaching the trust with a patient, and that's purely on the basis of capacity, whether it be through an emergency situation or not. So a patient has already called for an ambulance, and that ambulance is told to go elsewhere. The issue within North West London is we've found that the majority of accident and emergency departments are running at full capacity, and some of them are over capacity. So there's no real release valve for the ambulance, anywhere for the ambulance to go. What seems to happen now is that ambulances just queue outside with sick patients, vulnerable and very ill patients sometimes, sitting in the back of the vehicle, and they're unable to bring that patient into the hospital for proper care and treatment.
Can I just clarify? Are you saying that rather than actually going on divert, when a divert happens, they no longer divert, they simply wait? Is that?
Sometimes a divert, as it's supposed to happen, doesn't happen because there is no capacity for that ambulance to divert to.
What's the impact of nursing staff at the site when a divert is taking place?
Generally, when a divert is taking place, that department is already very, very busy. They're already running to full capacity, and as I've already mentioned, sometimes over capacity. Our members have been reporting to us increasing levels of stress, of work-related stress, of concerns about professional standards and the care that they're able to provide. One of the senior nurses from Northwick Park actually mentioned that she's having sleepless nights now, worried about the patient care that she's delivered during the day because she's not able to deliver the high standard that she would like to on occasions when diverts are happening.
And what, if you could sum up, please, for us, in your view, are the causes of that situation, diverts being put on?
The causes are generally due to lack of bed capacity within the system. So if a patient arrives at A&E, they're generally assessed, treated and discharged, or assessed, treated and admitted to hospital for further treatment. If a patient has to be admitted to hospital and there aren't the full capacity of beds for that patient to go to because the patient's already there, then there's a blockage in the system, and that blockage always backs up in accident and emergency. So if the beds are not available within that hospital unit, there's nowhere for that patient to go.
Your submission is dated, I think, the 27th of January. Are you able to assist with whether the pressures that you talked about at that stage have changed in any way since then?
My understanding from speaking to some of the trusts is that it changes on a daily basis. The trusts are generally working very hard to find capacity, discharge patients earlier than they might have discharged them before, to release free beds for patients in accident and emergency to be able to move into.
Are you able to say whether, in fact, the situation has got better, got worse, or is it more or less the same?
It's more or less the same.
Thinking about the proposed plans for Ealing Hospital and Charing Cross Hospital, can you encapsulate for us your view of the impact that will have, first of all, on patients? I'm thinking specifically about the A&E departments. What impact will there be for Ealing patients?
Ealing A&E department is already very, very busy. The nurses have told me that the patients were already worrying about what's going to happen, and the department hasn't shut yet. Those patients will then have, if they become unwell or they suffer an emergency or an accident, they'll have to make a decision as to where to travel to. There's a high level of concern about transport links and the lack of direct transport links to local hospitals. Patients already within the borough are confused as to whether to go to the urgent care centre at Ealing, whether they should go to the A&E department, or whether they should go to another A&E department. There's so much confusion already. The staff are already concerned about this.
And what about the impact on nurses in that situation?
It's the same. The nurses have very serious concerns now about patients and vulnerable and elderly patients actually staying at home and not looking to access care because they just don't know where to go, or if they do know, they can't get there because some of the surrounding accident and emergency departments are quite hard to get to if you don't have a car. So if you need to take public transport and you can't afford a taxi, they're very likely not going to go, and then we'll find sicker people at home rather than in hospital.
I wanted to ask you, in fact, a little bit about the linked issues of the transport element of things and the urgent care centres. Can you help with what your members' experience is of patients arriving at an urgent care centre who then need onward transfer? Is that something which you know to be happening frequently, or is it rare, or what?
The units that I cover have said that happens on a daily basis, and it does happen quite frequently. Sometimes the patients refuse assistance with transport to another hospital, and I can give you a very personal example. My mother did this, and she went to an urgent care centre in northwest London and was requiring a 999 ambulance to be taken to an accident and emergency unit because they were so concerned about her, and she refused. I had to go in my car.
Can you help us with how the transfer is supposed to be done between UCCs and A&E?
The UCCs historically were always meant to be nearby to an A&E department so the patients could walk over, or there'd be a wheelchair. But at the moment there is no formal system in place to enable patients to transfer directly from a UCC to an A&E. So there's no taxi there's no ambulance sitting there waiting to take people. It's on a case-by-case basis. Some patients require a 999 ambulance and some don't.
And what happens if a patient arrives and is found to need A&E and it's not on the same side?
Yeah.
Is there a backup plan if there's no ambulance available?
The urgent care centre that my mother went to, there was no backup plan. There were no medics available on site at all, so no senior doctors would be available to help my mother if she deteriorated.
Can I just ask you, because I wanted to see if something chimes with what you've said or not. There's a volume 4 bundle in front of you. I think it's literally the 4th one down. And I'll just ask you to look, please. If you could turn to, please, page 1239. And what that document is, it's an anonymised document from an emergency nurse practitioner. Yeah, if you flip over the page, about 3/4 of the way down, the nurse practitioner is talking about being in a care centre and nurses sometimes paying for taxis for patients to have onward care. I think it's the paragraph just below the one your finger is on. Do you have that? Do you see that?
I haven't come across that myself.
I was going to ask whether that's something you've ever come across.
No, nothing I've come across either.
Does it surprise you?
It doesn't actually. It's quite desperate, isn't it?
Thinking about the transport difficulties, what is your view then about the needs for accident emergency units and urgent care centres to be co-located?
My view is it's the most sensible option, and it avoids a disruption for patients who don't get it right. Patients don't know whether they have an emergency situation. Sometimes the doctors don't know even when they arrive. So from my perspective, they need to be nearby, co-located, or even on the same site to avoid any further disruption to patients.
And although this may elicit an obvious answer, what are the risks if they're not?
Well, they're life-threatening risks potentially.
And what are your members saying about the public's understanding of the difference between A&E and urgent care centres?
There's a lot of confusion out there. Some members of the public are very well informed, but for the majority of the boroughs that I cover, the nurses are reporting that the public just don't understand.
And in your view, are the difficulties in public understanding, are they teething problems or more systemic?
I think it's more systemic than that. Many people in the public have received documentation through the letterbox. There have been posters up at bus stops, all requiring, good reading skills, good command of English. And our members are saying that when patients arrive in A&E, they still don't know, in the urgent care centres, they still don't understand actually where they should have gone. They've just taken potluck.
I wanted to ask a little bit now about the community and primary care settings, which you say in your submission are also under strain. What do you say needs to be done in terms of resources and staffing levels to reduce that strain?
Increase, number one. So the community areas that we cover are suffering high sickness rates, high staff turnover rates. I spoke to a very senior manager within the Ealing Borough 2 weeks ago who told me she had serious concerns about the vacancy rates for community nurses and for health visitors, and the fact that she didn't have enough permanent members of staff to care for the patients on their current workload.
And so the impact of nurses who are working in this environment is what?
It's quite negative to the nurses, but what they're concerned about is trying to ensure that patients receive adequate care. At the moment, they've explained that they don't believe that they've been resourced properly or invested in for at least 10 years within that particular borough, but yet their workload has gone up. They have to see more patients on a daily basis, and because they've got more patients on their workload, they're spending less time, so there's possibly 15 minutes or 10 minutes to a patient visit. How much quality time is that with a patient? They actually want to give more to people, but they can't do it.
And so what, in your view, would the likely effects be of if the GP services, to which some of these nurses are allied, were expanded for 7-day a week?
The likely impact will be there'll be more people and more patients requiring community nursing services, and at the moment those services are not there on a full capacity 9 to 5 Monday to Friday. So we understand that weekends, that some GP services within the patch have increased their working on a Saturday, for example. Our practice nurses are reporting that they're having to increase their hours and some of them are working excess hours that are unpaid to meet the demand, but that there's no backup service within the community to provide, for example, dressings to elderly patients, injections and treatments to vulnerable patients, people that have mobility problems. It's just not there. So at the moment, the impact is on patients having to be further inconvenienced, leave their houses and go back to accident and emergency or an urgent care centre to receive those treatments.
And just thinking about the out-of-hospital services, within your knowledge and awareness, what new or enhanced services in the borough do you know of, or in the region in fact?
There's one specific service that I understand has happened within Hammersmith and Fulham. In the community, they've started to look at the community as a virtual ward, and they've put into post new care coordinators, which are people who coordinate this virtual ward. So if you imagine a patient at home is a bed on a ward, and that's how they're trying to coordinate that particular area. I don't know of any other new initiatives across North West London, and I cover Hounslow and Richmond, Ealing, Brent, Harrow. I cover Park, cover Hillingdon. I don't know of any new initiatives in those boroughs.
So bearing in mind that position, do you consider that it is currently safe or unsafe to reduce acute facilities?
At this current time, I believe it's unsafe to reduce those acute facilities.
What would need to be in place to achieve that aim safely?
We would like to see proper investment in community services. We'd like to see proper testing of some of these new community services that we've been told about. There's no data at present to support that patients have received a benefit from any of the changes so far, and we would like to see some of that data. We would also like to see the professional organisations around the table with the people running the project to talk about the clinical impact on patients of these changes within the patch.
Finally, I just want to ask you about Ealing Maternity Hospital. It seems now that the decision which was to have been taken, I think on the 18th of March, has now been put back again to May. Can you assist with what effect the delay, rather than the decision itself, is having on the nursing staff who are working there?
We have a good proportion of Royal College of Nursing members working in that unit, and the delays have had such a dreadful impact on their morale. We've seen midwives actually leave the NHS to join agencies because then they feel that they'll have a bit more security working with an agency. Can you believe it? The staff there are working under pressure already. They're quite short-staffed. They're absolutely devastated with this, and they've reported that to the LCM.
And again, in terms of the delay, are you able to help with what the effect of the women is on the women who are using the service?
We now understand that patients have been contacting Ealing, asking why they can't have their babies at Ealing, the women wanting to have their live births at Ealing, because they were aware that the closure was going to happen. They were already making plans to go to some of the receiving trusts, and they don't want to do that. So we've been told by senior nurses at Ealing that the patients are very unhappy, that they're not getting their choices.
Thank you. If you wait there may be questions from the commissioners.
Yes, thank you very much again for your presentation. I have a question which maybe, I know there's further evidence to come from other witnesses about this, but I'd like your help. In other words, standing back and looking at the population that's being served. First question is there a correlation between numbers? In other words, the percentage of a population can be related to the number of A&E facilities that are required. In other words, is there an optimum number that you need to have? 200,000 comes to mind, but I know that's a figure that comes up later. And does that make any sense? In other words, you could have a smaller population with a bigger need or a bigger population with a lesser need. In other words, how does this work? Am I right in thinking there's more than one type of A&E at the moment, which the public may not be fully aware of what the types of A&E are? So that's the second part of this. And does any of the urgent care centres, by definition, equate with any of the types of A&E that you have at the moment? I'm sorry, it's a three-part question. Have you followed all right, or have I gone too far?
Almost about capacity, I don't know that one.
We usually hear that the capacity, that the population is about 250,000, around that amount for an A&E department, full functioning A&E department. And
Can I just interrupt? How do they calculate that?
Population status and the demands of the population.
So it is worked out on demand?
Yes.
All right, sorry.
I think, yes. The other question, the second question was the types of A&E.
Right, with the types of A&E, I can't remember the question to be honest, but my understanding is that the public do not realise that some A&Es have a different level of service to others. So for example, in North West London, you would imagine that every A&E would offer the same backup service to patients, but we know about specialist centres that are currently running. So for example, we have stroke units in some hospitals to back up their A&E, they're not in others. So if you are having a stroke and you go to A&E because that's the right place to go, you're very often transferred by 999 ambulance to another A&E. So that's the answer to that. I don't...
Yes, so I haven't quite answered. So even you don't know then how many different types of A&E there are at the moment?
A&E is A&E, so accident and emergency departments are supposed to provide frontline, first-line care to patients in an accident or an emergency. It's more about the backup services within the building, within that trust, as to what the A&E will offer. So if the trust does not have a stroke unit, I'm giving that as a broad example, if it doesn't have a stroke unit, and many of our trusts in North West London don't, and the patient has presented with a stroke, they have to be transferred away from that A&E to an A&E that has a stroke unit to support it.
So, sorry, I'm just trying to follow this through practically speaking. In terms of what an urgent care centre, if this is going to be the model for the future. If you're going in the middle of the night with something that presents or may present as a stroke or some cardiac problem, then who's making the decision? Is the ambulance crew deciding, oh, we'll take them there, or is it a hospital saying, you've got to go over there?
It's a combination. So the ambulance crews, the ambulance service provide quite strict protocols, and if the patient fits the protocol and they suspect that there's a stroke happening or a cardiac event happening, then they automatically will take that patient to a hospital that they know has that receiving specialist unit to support the A&E department.
All right, well then as a follow-up question, would you say that in fact what should be happening is that all hospitals that have an A&E facility for the 250,000 population should be able to cope with all the necessary ailments that may come into the category of emergency? In other words, whether it's a stroke or whether it's a breathing problem, whatever it happens to be, acute problem, each A&E hospital should have the same standardised facilities. I mean, do you believe that's an important follow-up?
That, in my view, is ideal. If you're going to offer an A&E department service, then you should have the support behind it.
Yes, certainly.
I mean, I'd like to take you back to the concept of the virtual ward. Hammersmith and Fulham is a virtual ward. And someone said to me just recently, if you're going to have a virtual ward, then you have to staff it like a ward. And I'd just like you to go a little bit more on the various skills, the various professional staff that would be needed, and what your idea might be of adequate staffing of a virtual ward the size of Hammersmith and Fulham. Who would you need, and how many roughly of them? Let's say, let's guess, I don't know, 200,000 population, let's guess.
It's very difficult to actually say those numbers, because there would be a number of people within the virtual ward, and I think the staffing for the ward would be maybe similar to what it would be within a say a hospital ward. However, maybe you've got 20 patients, 28 patients in the community, you will need different skills because the nurses there don't have the next person to look after them, to say colleague. They have to be more skilled up, more district nurses available, and more people working on an independent basis to be able to make those decisions, do the full clinical assessment of the patient, and then call in therapists that they need to be able to prevent the patient from staying at home. But those people need to be experienced because they need to be able to make that decision. Is this person safe in their bed at home?
So in other words, in order to make that a reality rather than simply a virtual idea, you need to actually put a certain component of staff that need to be available in a properly organised unit to deliver
in a properly organised base, from a base somewhere, or maybe two bases within the borough.
Is there any sign of that actually emerging in Hammersmith and Fulham?
I understand that they have started some work on that, but that's not fully developed. But they have started.
Sorry, what does that mean?
They've employed 2 new members of staff. They're calling them care coordinators, and their role is to create this virtual ward and to manage it, set up systems and processes that are safe for patients to be cared for at home. So it's a new initiative.
So it's not really off the ground, practically speaking.
Not fully running, no.
Can I explore that a little bit further? I'm particularly interested in what your thoughts are about how far the outer hospital services have gone in preparation for whatever changes might come. So, for example, I have here a list of, say, 15 proposals from the Hounslow CCG, which I think is piloting Chiswick, my old stamping ground, actually. And there are 15 proposals here. I could quickly run through them: ambulatory blood pressure monitoring, 2 levels of anticoagulation, case finding, care planning, case monitoring, coordinate my care, 2 levels of diabetes care, ECGs, homelessness, phlebotomy, ring test, spirometry, and 2 levels of wound care. Now, my old practice used to do most of these anyway, so I'm trying to find out how would their proposals prevent admissions. Now, I'm interested in that respect of case finding, care planning, and case monitoring, and coordinate my care. You mentioned coordinate my care, but I'm not certain how that would prevent actually admissions. Can you tell me, do you know anything about case finding, care planning, and case monitoring in respect to preventing admissions? For example, I know putting a ring pressure isn't going to prevent an admission, or measuring spirometry instance. Maybe complex wound care might, but then we used to do that anyway in the treatment room. Can you explore and tell me how you think any of those might prevent an admission?
Well, we understand from our members that the theory is about preventative medicine, so it's about screening, health screening, trying to identify when abnormalities are about to occur and getting, some treatment for that patient in the community. It's questionable about whether that will actually have the effect of prevention of admissions to hospital. I don't know if there's any data available to support whether it prevents. I've not seen any of it. So.
But certainly you and your colleagues have been doing complex wound care for years, haven't you?
We have. Yes.
That's not a new thing, is it?
No, certainly not. We're the experts on wound care.
Yeah, as I know. Thank you for your help over the years.
Thank you very much for your evidence.
Thank you.
Thank you.